Welcome back to the Canadian Concussion Center's webinar series, which is sponsored by LIUNA, the Laborers International Union of North America. My name is Leslie Rattan, and I'm pleased to be moderating our series, which was developed for individuals that have suffered concussions, their caregivers, as well as healthcare providers. And the sessions, for those of you that haven't been with us before, recur every other week, live on Tuesday evenings from 6 to 7 p.m. And just so you know as well, all of our sessions are recorded and archived on the Canadian Concussion Center website. So you can always go back and find a presentation if you missed it or want to watch one again. Thank you very much, Christian. He's just put the link in the chat. Our sessions usually they focus on various aspects of concussion, and we typically have an expert speaker who is with us and presents for about half the session, and that's followed by a question and answer segment where you can get your questions answered. So just to orient you a little bit, if you just sort of move your cursor, you'll see that there is a chat icon at the bottom of your screen. If you click on there, you'll see that Christian has entered the link to our previous webinars. And then there's also a Q&A button at the bottom. So that's where we would ask that you put, if you've got any questions for our speaker tonight, please enter them there. If you're having any technical difficulties, please enter those into the chat and Christian can give you a hand. Just before proceeding any further, we always like to acknowledge the Indigenous peoples of all the lands that we're on today. Even as we meet virtually, it's important to recognize the lands we each call home and reaffirm our commitment to improving relationships and understanding with local Indigenous peoples. From coast to coast, we honor the ancestral and unceded territory of all the Inuit, Métis, and First Nations people that call this land home. And just before I go any further, we're just going to run a quick poll. We always like to get a sense of who is in our audience. So I'll just give Christian a second to bring that up. Okay, perfect. So for this evening's session, I'm really happy, pleased to introduce Dr. Kristine Dalton, who has returned to speak to us again on post-concussion optometry. Kristine is an associate professor at the School of Optometry and Vision Science, an optometrist and a leader in the field of sports vision and concussion rehabilitation. After establishing and directing the Vision and Motor Performance Lab in 2003, she went on to found the Sports Vision Clinic at the University of Waterloo in 2004. Under her leadership, the Sport Vision Clinic expanded its service to include the Brain Injury Clinic in 2019. In her clinical work, Kristine provides performance vision enhancement and vision rehabilitation services for athletes and individuals with traumatic brain injury and concussion. Kristine has published over 20 papers and 80 conference presentations and supervised over 40 undergraduate and graduate students. Her research interests include sports performance, traumatic brain injury rehabilitation in able-bodied and para-sport, and Paralympic classification for athletes with vision impairment. Her work is helping to develop one of the first sports-specific classification systems for para-athletes with vision impairment, as well as national and international guidelines on concussion management for para-athletes and in optometric clinical practice. Kristine is also a member of the Concussion in Parasport group, a fellow of the American Academy of Optometry, a fellow of the British Contact Lens Association, and a recipient of the Excellence in Science Teaching Award in 2018 from the University of Waterloo. So I'm so happy that we've got Kristine here, so I'm going to turn it over to her.
Thank you for that kind introduction, Leslie. It's absolutely an honor to be here. And for those of you who are wondering, the furball who's joined me, his name is Logan. And he will probably keep us company much of the evening. So it's an absolute honor to be here, and I'm really excited to share with you some of the things I'm passionate about and the role of optometry post-concussion. So to get us started, I just want to take a moment to orientate us all to the visual system. I'm hoping everyone is able to see my slides now. But when we think of the visual system, we often think of just the eye and the glasses and contact lenses people wear. And that certainly is part of our visual system. That is our optical system. That's where all the visual information comes in. But as part of that visual system, we actually have all of the areas of the brain that process that visual information and allow us to use it and interpret that information to navigate the world. So our visual system really composes of both the optical system and then the perceptual system as it navigates and the visual information is processed in the brain. In addition to the visual system, we also have the vestibular system, which contributes and connects to the visual system. So this is our system that helps keep us steady and control our balance, and is a connection between the semicircular canals in the ears and also the muscles in the eyes, and allow us to, as we move and navigate space, for our eyes to adjust and move around our head position to help us maintain our balance and our line of sight following head injury. So on the screen now, you'll see there's a number of different symptoms. These are all really quite common as symptoms associated with concussion and mild traumatic brain injury. And what's really fascinating to me, and still every time I think about this information or the work that we're trying to do, why it's so important, is that if I were to push the button again, now you'll see a number of these symptoms actually overlap with common symptoms related to vision issues. So there's quite a big overlap in the symptomatology of head injury and also some of the underlying vision issues we see post-concussion. And as research continues to go, we're starting to learn more and more over day, but this message has been consistent now and confirmed in many papers that up to 90% of people experience some sort of vision symptoms after the concussion, regardless of their age, their injury mechanism, or their injury severity. And while not all of those become persistent, there's certainly periods where most people experience some type of vision symptom after their head injury. What we're now learning more and more, and it's being shown in different populations. So this early work came out of adolescents, but it's certainly showing up in other places now, is that if there are vision and vestibular problems, so deficits in the visual system that we can measure or deficits in the vestibular system, even early on following a head injury, they seem to be predictive of a prolonged recovery and more predictive of people developing persisting symptoms. And that's important to consider because those persisting post-concussion symptoms are associated with poor health-related quality of life scores across all age groups of people, so adolescents, youth, adults, and older individuals as well. When we think about vision problems associated with concussion, there are a number of different things that can go wrong. So there include things with accommodation defects. So these are accommodation systems are kind of like autofocus on a camera. So it adjusts to allow us to see distance vision clearly and near vision clearly. And it's the system that as we get older, we need help with reading glasses to accommodate for and help us see clearly and near. And so this focusing system can be impacted following concussion and can sometimes have impacts and knock-on effects on our glasses prescriptions, either for distance or near or both. We can have issues with eye movement problems. So either with the eyes, how they turn in and they turn out to keep the sweet spot of our vision on what we're looking at. So the eyes will turn in so we can look up close and keep things single and clear, and then turn out to allow us to see in the distance. And there can be issues with that system. Or there can be issues with the eye movements we use to track moving objects or to look between different objects, or sometimes even to look at a steady object and focus on it. Light sensitivity or photosensitivity is common following concussion, and this can contribute to screen intolerance, issues with phones, computer screens, fluorescent overhead lights, certainly, but photosensitivity is common. And then we see those vestibular deficits, so connected to the vestibular pathway from the ear, and then links into the eyes there, which can impact balance, coordination, and also contribute to issues with motion sensitivity, and sometimes even issues with driving and transportation and navigating the world. With these common deficits, a lot of the symptoms that we see associated with these include things like headache, issues concentrating, trouble focusing, trouble with reading, certainly difficulty tracking objects, and certainly we'll see issues sometimes with balance and spatial awareness as well. And while I can say those fancy words and kind of try to describe them with my hands, they don't really help. It's really hard to understand how anybody else sees. So I have a few images to share with you to kind of give you an idea of what these experiences might feel like. The first is an accommodation deficit. So this is where the text is single, but you just can't get it clear. No matter how hard you try to use the focusing muscles in your eyes, the text just never comes crisp and clear. And you can certainly imagine how difficult it would be to try and navigate the workplace or school or any sort of book or phone or screen work when the vision just isn't as clear and crisp as it could be. And you're exerting a lot of effort to see clearly, but still it's not getting there for you. When it comes to those convergence deficits or the deficits in how well we turn our eyes in and are able to maintain the eyes in that turned in position to see single and clear up near, that causes almost a doubling or a ghosting of text. And so in this text, the text is clear, it's high contrast and it's clear, but we're starting to see doubling of all of the letters within that text, which again makes it really challenging and hard to read. The last group of common deficits that I'll demonstrate include the eye movement deficits. So we can have fixation deficits. So fixation is our eye movement. We're looking at something steady in our visual field. And normally that's really just a relatively steady gaze, right? The eyes stay stable. We can concentrate on what we're looking at. But sometimes following concussion and head injury, that actually becomes unstable. And we aren't able to fixate on things as accurately as we might like to. Our pursuits are a smooth tracking eye movement, so they will track if we're watching something as it moves. That's we're using our pursuit eye movements, and normally they're quite accurate. So our eyes will track and follow things like this arrow as it moves, and they can be quite accurate. But following a concussion or a head injury, there's often a disconnect between that, and so we will see that our eyes do not track objects as accurately as we would like them to do, and that can create some issues that way. And then we can have saccadic defects. So these are quick eye movements between two targets that are further apart. We use them all the time, including when we're reading. And normally, when we make a saccade, they're accurate. They land on the target we're looking at and they'll return to their origin position. But following a concussion or a head injury, they often overshoot or undershoot. And so we have to make corrective eye movements in order to be able to get our vision accurately to the place we're trying to look at. In addition to these common vision problems, we can have a number of other issues. So issues with our pupils and how they react to light. We can have issues with how well we see contrast, so differentiating different shades of gray. And we're starting to realize now over long-term changes, seem to be long-term changes in the actual structure of the retina itself. We're seeing changes in how the brain processes visual information. So the visually evoked potentials are a measure of the vision signal strength that's being sent to the brain. We're seeing changes in visual perception and also some changes along the primary visual pathways within the brain, suggesting that over time, or certainly with repetitive head injuries and longer term, there are impacts on the eye from the head injuries as well. And I'd like to one of the big take homes for me, if we think, in addition to the fact that vision issues are common following concussion, is actually also that it's really common to have more than one vision disorder. So this was studied done a number of years ago. On each of the colored circles on the graph indicate a particular vision disorder, the convergence disorder, so turning the eyes in, an accommodation disorder, which is focus disorder, or that saccade disorder. But almost half the population of kids in this study, about 46% of them, had multiple disorders, sometimes two, sometimes three. And it's really common and consistent with what I see clinically is that we see a constellation of issues within the vision system, and they're not consistent or predictable between people. So when I'm wearing my clinical hat and we're thinking about optometry and its role post-concussion, optometrists really aren't involved in the acute concussion management stage. That's not really our role. I don't think at this point in time, that's not where we need to be providing care. We really get more involved in the management of patients with persisting post-concussion symptoms. And we're a part of that patient's multidisciplinary care team, right? We're there to support and facilitate recovery and work within that team. From an eye exam perspective or from an optometry perspective, we don't have a gold standard of care yet, but certainly with the evidence that's coming out and continuing to do research in this area, we're really starting to understand that following a head injury, you probably need a two-part concussion vision assessment. So one is really your standard full eye exam, including a really good refraction where they check your glasses prescription for any changes, and an ocular health assessment with a dilated fundus exam. In addition to that, you need a really detailed binocular vision assessment. So looking at how well the two eyes work together, and then also looking at the ocular motor pieces. So how well the eyes are moving within space. And then overlapping that, we also need to be mindful of other types of vision deficits. So things like the photosensitivity and the motion sensitivity and other experiences people have with their vision. And then as optometrists, we recognize the eyes are only a piece of the whole story and the eyeballs are in whole humans. And so we're also being mindful that we need to pay attention for other issues, be them cognitive impairments, neck pain, any, vestibular issues that might warrant further referral on within that multidisciplinary care team to support individuals at large. When we think about managing vision issues post-concussion, step one really has to be addressing any structural abnormalities. So if there's any ocular health issues or structural abnormalities within the eyeball itself, those need to be addressed as a priority. Following that, we need to think very carefully about prescription and light sensitivity. Those need to be addressed next. And then if those two aren't enough to combat the issues or challenges people are having, then we can think about how we might address those visual function deficits and visual perception deficits through things like vision training as one of our options for treatment. It's pretty important to think about injuries, and I say structural injuries, I don't say that lightly, particularly in sports. Sports-related eye injuries are about 10% of all eye injuries requiring medical attention. But if we think about our basic anatomy, our eyes are in our head. And so if we have a substantial head injury, it's possible we could have a substantial eye injury as well. And what's really, really interesting is when you start looking at what causes eye injuries, anywhere from pretty much the eyelids all the way back to the optic nerve and the bones that surround our eye and protect it can all be injured in an ocular injury or sports injury. And so when it comes to head injury, we need to make sure the eye itself is safe and intact. We then need to think about the prescription. So I alluded to the focusing issues with the accommodation system. Defects within the system are quite common following concussion, and we can have either the system becomes overactive and it creates almost like a Charlie horse or a spasm type response that can create almost a myopic refractive error shift. And in other patients, the accommodation system becomes underactive and we actually need to add reading glasses or a hyperopic farsighted shift. And so depending on what's happening within the system, we will need to address prescription issues accordingly in an appropriate way for individual patients. And certainly getting an accurate spectacle correction can improve persisting post-concussion symptoms for people and really needs to be a first step in care. In addition to that, we need to think about tint trials. So photosensitivity is a big thing following concussion, and there's a variety of different tint options available to patients. I've demonstrated some on the screen here that are blues and purples and kind of rose-colored lenses, but other patients like yellows, some like grays, some like brown lenses. And there's no perfect tint for people right now. The tint that works best is the one that gives you substantial symptomatic relief in your routine environments. But if there is photosensitivity and we are looking at doing a tint, this needs to be addressed early on with the refractive error correction. And ideally in a way that the tint can be put on and removed from the lenses and kind of used as needed so that you can still habituate to normal lighting conditions and try to continue to progress with recovery rather than being in that tint full time. Obviously, if recovery has plateaued at some point in time and the tint is a full-time need, that's fine. But early on, it's nice to be able to take it on and off of your glasses as needed to help facilitate recovery. So really, from a refractive perspective, we're looking at correcting refractions as accurately as possible, ideally working full-time with those new corrections, giving the eyes time to get used to them, and then reassessing the visual function after that, after you've had the glasses and the time to adapt to them, and then determine if additional interventions are needed. So I usually recommend people take 3 to 4 weeks to get used to their new glasses, and then we'll reassess their visual function and determine if they need vision therapy or additional interventions at that point in time. So vision therapy is a type of therapy that's typically provided by optometrists with specialized training, but it can be provided by other care providers as well. And it can be of benefit for some patients with oculomotor dysfunction with persisting concussion symptoms. Really, vision therapy is kind of like physiotherapy, but it's targeted exercises for the eyes, and it can be done either in the optometrist's office or at home. Both types of therapy, whether it's done in office or at home, can be effective for patients. The modality that works best is the one patients actually can do and engage with around their other schedules and appointments and life demands. But really the key thing, I think, before we start vision therapy programs is we still have to address prescription issues first and structural issues first. When we think about vision therapy and in the research, it's still an area that there's a lot of research that needs to be done and is continuing to be done. But at least from some of the work that's come out, vision therapy appears to be most effective for those accommodative or focusing deficits, the convergence deficits, and the eye movement deficits. And in patients who have those types of deficits post-concussion, the vision therapy also appears to be helpful for the symptoms they experience, or at least some of their symptoms, maybe not all. And so it's certainly that vision therapy is, where appropriate, makes sense for patients with persisting post-concussion symptoms who have visual dysfunction, and can be an additional tool in their recovery toolkit. When we think about what we're doing with vision therapy and what we're trying to achieve, our goals are really to make sure the eyes are functioning independently, so monocular or one eye at a time first. And that's really looking on the focusing systems and those fixation controls and those eye movement pieces, because the eyes need to work as individual units well before we can stick them together and see how they work as a unit of two. Once we establish that good monocular function, then we're looking at incorporating binocular functions, so things that require both eyes, working on integrating how the eyes, retraining those eyes to work together in an efficient and comfortable way for patients, and working on those eye movements to either turn the eyes in or out as appropriate, as well as bigger and larger eye movements from there. And overlaying all of that work, we're going to try and incorporate some work on things like visual spatial awareness. So peripheral awareness is one piece. We may work on some vestibular function pieces or collaborate with a physiotherapist to work on some of the vestibular pieces. We'll think about coordination. So visual motor coordination, how do we react in response to visual information? Maybe some tolerance training or desensitization training for visual motion tolerance. But really, as we start to move forward into these more complex visual functions, it should be done in a collaborative way within the patient's healthcare team. When it comes to other vision therapy options, there are other treatments out there, and I'm sure these are familiar or things people have heard of, things like binasal occlusion, endiope prisms, and syntonics. These are other treatment options that are available, but they have even less evidence supporting them than the traditional vision therapy methods. So these may be appropriate for some patients, but they typically aren't my first line choice of treatment. My first line treatment is really refractive corrections first, and then some of the more traditional vision therapies. And then if we're still not making progress, then I might consider some of these. But these really need more research at this point in time to determine if they're effective for persisting concussion symptoms or not. When it comes to how long your vision therapy program should be, we're still learning. It's really in a case-by-case basis. I imagine as many learn about concussion across these seminars, they are really unique injuries. So there's lots of general things we can say about them, but really there is, in terms of specific concerns with concussion, it's in a specific individual's journey, they're all unique. And so that seems to hold true for vision therapy as well, in that there is no set duration, there's no magic number of sessions that will fix vision issues following concussion. And so what I strongly recommend, or what I encourage, is that your progress of the vision therapy program is monitored closely. So we check in every kind of 1 to 2 months and check your numbers and see if it makes sense to continue on with therapy. If I'm doing an at-home program, I tend to check back in with patients every 4 to 6 weeks. If I'm doing an in-office program, whether that be a vision therapy session every week or every 2 weeks in office, where they're coming in to do training with me specifically, we don't tend to do more than 5 sessions at a time. So we'll do 5 sessions in a row, and then we'll reassess visual function and decide whether or not it makes sense to continue the program. So checking in more frequently and using those smaller doses of training interventions can help be supportive to make sure that we're continuing to make progress, and the investment in therapy is worth the time and money that it costs for people. As we're wrapping up, there's just Leslie mentioned that I'm also involved in the parasport space, or in the space for athletes with vision impairment, and certainly individuals living with vision impairment. And this research in this space is still quite limited and new, but it is growing. But it's an area we're starting to understand that people who have vision impairment, and certainly para-athletes with other disabilities as well, but they experience concussion injuries differently. Many of us will think about having double vision or blurry vision from a concussion, but those may be the normal state of affairs for someone with a vision impairment. So their vision may always be blurry, or they may always experience double vision, or someone who has total blindness may have no vision at all. And so their concussion experience may look very different than someone who has the ability to see and drive. And so what we're starting to realize in this space is that concussion head injuries, at least in the parasport spaces, are comparable in their incidence rates to those in non-disabled sport. And actually, concussion rates are often higher in athletes with vision impairments in particular, and also in female athletes in these spaces. But one of the challenges with, in particular, in athletes with vision impairment is it can be challenging to recognize the concussion symptoms sometimes and to differentiate those from the symptoms that pre-exist with their vision impairment. And so there's been some really nice work done. So the first position paper came out in 2021 on the concussion and parasport group. But for individuals interested in learning more about this space, the concussion and parasport group went through, at the time it was the SCAT-5s, now we're on the SCAT-6 versions, but went through the concussion assessments and the management guidelines from the concussion and sport group and actually flagged using a traffic light system of red, not effective, yellow, possibly effective with considerations, and green. I mean, you can use these recommendations with no concerns for people with vision impairment, people with physical disabilities, including wheelchair users, amputees, and people with spastic conditions and other conditions like cerebral palsy, and also individuals in intellectual impairment. So there's a resource there. It's freely available and can be downloaded from BJSM for those who are interested in more information on this space. In addition, for individuals living with vision impairment or who are experiencing vision impairment of concussion, it becomes really important to have that optometry exam, possibly earlier on in the process, to help understand what aspects of those vision symptoms a person experiences are related to their vision impairment, their underlying eye disease, and what aspects might be related to concussion. And that's another place where optometry can play a role, is really helping and supporting the diagnosis of whether or not the symptoms are concussion related or not in an individual. And then we can also help support with accommodations for individuals, both with vision impairment and actually individuals without vision impairment, to return to workplaces and to return to school. The Canadian Blind Sports Association has put together some nice concussion resources for accommodations, recommendations for accommodations and adaptations for individuals with vision impairment, particularly athletes, but things like accommodations and recommendations for returning to work and school, and also for returning to sport in these communities. And those resources are also freely available at the link that will be shared on the slides as well. And so in summary, as we wrap up, I think optometrists really, our role is to help determine if there are vision deficits present in individuals who have suffered from a concussion and have persistent concussion symptoms. We need to do that with careful assessment of structure, with careful assessment of eye exam, or of prescription, certainly a dilated eye exam, and then a careful assessment of prescription. And then we can help support interventions as well. So we careful assessment of the visual system, and then we can help support treatment through glasses, refractive corrections, and then potentially vision therapy in some patients where appropriate. But like with everything in this space, I think, or certainly with lots of things in this space, we continue to need to do more research and continue to do more work to help understand dosages, durations, effectiveness of what should be done first. Should vision come earlier, or should, vestibular rehab come first, or should, musculoskeletal cranial sacral neck work come first, and how those kind of treatments interact and work together. Certainly, we still need lots of work in those spaces. So there's still lots to be done. Fundamentally, because we don't always have all of the best research guiding everything, and even with research, fundamentally, we still need to make sure that all of our management decisions and all of our care decisions are patient-centered and focused on trying to address the needs and concerns of that individual as a patient, because each of their journeys is unique and the factors that they are navigating in their own lives is unique. And so approaching this from a very holistic approach, focusing on that individual as a human, and then working really carefully within their team to help support their journey, is really where optometrists can play a role and contribute to rehabilitation. And so with that, I will say thank you kindly for the opportunity to present.
Great. Thank you so much, Kristine. The questions are pouring in. So I think, yes, your slide about the frequency of visual issues post-concussion is absolutely true. Stuart is asking, so how long post-concussion should someone wait before being referred to an optometrist for an ocular assessment to see if there's an ocular component that needs to be addressed?
Yeah, so I think, Stuart, where that comes from, really, we don't know yet. I mean, I'm involved in some research trying to understand how early those referrals maybe should be made, and how and when those decisions should be made. But really, we're looking at probably when you're considered as having persisting symptoms and not recovering within the normal time frame, that's where maybe if there are vision symptoms or things that you're experiencing that you think might be visual within your injury, that's a good time to be looking for an optometry referral. So in adults, we're thinking probably around that 4 weeks mark, 4 to 6 weeks, and same probably closer to that 4 to 6 weeks in kids, if they're not recovering kind of as expected. That may be a good time to have that referral made.
Great. Thanks so much. Does the use of prism preclude the requirement of tinted lenses, i.e., if the prism is used, then it would help one to process the light or so, and then tinted lenses would not be required. They're wondering if that's correct or not correct.
So prism and tinted lenses do serve two different purposes. So prism lenses have two purposes in their own. So prisms can sometimes, if there's a habitual misalignment in how the eyes rest in their native state, we can actually use prism lenses to move visual information so it lines up perfectly on the macula or the sweet spot of the vision in each of those eyes, and then it doesn't take effort for people to see single and clear. And those are typically called relieving prisms, and can be prescribed for various binocular vision defects, including some of those that show up following concussion. We can also use prisms in a yoked way, which means the prisms kind of shift your visual world in one direction or another. Sometimes those can be helpful for people following concussion, not always. That's one of the treatments that we have less evidence on, and so certainly isn't a first-line treatment for me, but for some individuals, seems to be helpful in certain circumstances. But both of those things are really related to where prisms really shift where images are in space. And so they will try to move images in space so that you can see more comfortably. Tints are really about the light sensitivity and the glare you might experience in your environment, and they're really about filtering that. And so prism doesn't really get rid of the need for tints. It doesn't cut the brightness of a screen. It doesn't cut the brightness of fluorescent lights, but it makes it easier for you to see comfortably. Um, Sometimes seeing more comfortably means maybe the lights don't bother you as much because you don't have to work so hard to see clearly. So that in that way, prisms may help reduce your need to rely on tints, or maybe we don't need them as often. But they're kind of separate pathways, and we need to sort of address them for each individual and look at how we can make their vision as comfortable as possible.
Okay, that's great. Thank you. Anne is asking, are optometrists typically able to address refractive issues, or should that also be addressed by someone who has specialized training related to concussion, like vision therapy?
So optometrists can absolutely address refractive issues. That's one of the things we do in almost every routine eye exam. I will say what I've learned from experience in patients with concussion is that sometimes we need that accommodation system can kind of cramp up and Charlie horse. And so sometimes as an optometrist, I need to use drops in the eyes to get a very accurate prescription reading and relax those focusing muscles. Those drops are they're like the dilating drops. So you can either do it, check your prescription after you've had your eyes dilated for a retinal health exam, or you can use drops, which are called cycloplegic drops, which are even stronger than the dilating drops. And those relax all the focusing muscles in the eyes. And that sometimes helps us get around those focusing system issues to get a really accurate prescription. But optometrists absolutely can check refractive corrections. That's really what we do almost day in and day out.
Okay, great. Thank you. Uh, here's one. Why do neuro-ophthalmologists not support vision therapy as a treatment for vision issues after concussion? I know it's a controversial.
Um, that's I think we all have different skill sets, and I think the evidence in vision therapy, certainly from a scientific perspective and a clinical trial perspective, is still limited. Um, that it is in infancy. We're trying to do the work, but historically, in a lot of the concussion research space, optometry didn't really step up very well to say we could help support patient journeys as a profession, and we weren't always included in conversations from other directions. So I think we have good skill sets. We have things that we're familiar with, but I think we need more research in the vision therapy space. And I think that's fair, right? I think neuro-ophthalmologists, so vision therapy can be expensive. It doesn't always work for everybody. And so one size fits all model in vision therapy also isn't great. And so some of those concerns can be valid. And it's just trying to walk through a path that makes sense for each patient as an individual, and trying to be thoughtful about the research we do and transparent with our recommendations. And I think if we can do that and have conversations, then we get to a better place in the end.
That's great. Thanks so much. Sarah is asking, how common is narrowed peripheral vision that requires retraining? She said it worked for
Um,
me, syntonics and horizontal prism therapy glasses.
yeah. So certainly awareness of our peripheral field, so we can it can certainly be a big issue following concussion. So we can have sort of that narrowing or that sort of tunneling of vision where you aren't using your peripheral vision as effectively as you could be. And we also have individuals that so it can be quite common to have that experience. It can also be common to have individuals who struggle to ignore information in their periphery. So it could be really, really distracting. And training can work on both of those issues, either to help you become more aware and use your peripheral vision more effectively, or potentially to learn to ignore things in your peripheral vision more efficiently as well.
Great. Thank you. Heather's asking, do you feel that a neck injury with a traumatic brain injury can affect your visual functions?
Absolutely. So a lot of the cranial nerves that control how our eyes move run through, the base of the skull, come through in the base of the skull and some of the neck. And so when there's overlap between craniosacral neck injuries, certainly jaw injuries, vision issues, cranial nerves that run through the face, that there's a lot of pieces there that can impact and compound on each other. And I make actually a lot of referrals out for patients with vision stuff that doesn't seem to be getting better into physios for neck work to see if there's other persisting
Mm,
neck issues or underlying things that are blocking some of the rehab if it hasn't been explored. Because there's certainly relationships, although we don't have the best studies yet to draw those out in really evident lines. There's certainly relationships there.
great. Thank you. What is the time frame between the incident, so having the concussion, and then the visual symptoms showing up?
That's a great question, and I think it can actually be quite unique and individual dependent. So some people will notice vision changes quite early on, but some of the vision symptoms that we'll see experience often don't show up till later. So if you have a lot of really intense early on symptoms and you're nauseous and you're not feeling well and you're dizzy, you're probably not going to realize you have trouble reading a book because you haven't even picked one up. And so some of those visual deficits can actually show up later when we start to go to use our visual system to re-engage with returning to work, returning to school, getting back into those routine activities. And we can sometimes have stuff manifest later too, because we just haven't been utilizing it in the same way early on.
Mhm. Okay, thank you. What can be done about screen sensitivity, specifically getting headaches every time I look at a screen?
It's a great question. So screen sensitivity is a complex problem. Some of it is making sure your glasses prescription is accurate for the screens and for how well you see, because uncorrected prescription can cause glare and light sensitivity. Some of it is thinking about whether or not a tint or filter was appropriate. I know at the University Health Network with Dr. Charles Tata, they're doing some studies trying to understand the pathophysiology of screen sensitivity, and what those mechanisms are that are driving it so that we can start to understand the underlying mechanisms and maybe develop better treatments. Sometimes there's non-flicker screens that can be helpful. But some of the other things that can also be helpful for some individuals, sometimes people find blue blocking tints help, sometimes they don't. But one of the things I often recommend for patients is just to turn the brightness down on their screens. It actually cuts a lot of the blue light just by turning your general brightness down overall. And that can be really helpful. You can also flip the polarization of your screen so that you're reading white text on black background. For some people, that also helps reduce some of the glare and issues of screen sensitivity as well.
Great, thank you. Yeah, and just to flag as well, we actually do have an entire session that Dr. Tatter did on things that you can do for screen sensitivity. So if you go to
Mm-hmm.
the Canadian Concussion Center website, you can find that there. Are you familiar with the Pinnacle Multisensory Reset Program? Can you please share your thoughts on it? And are nighttime vision issues a result or a factor of related to post-concussion symptoms?
Those are two good questions. I actually haven't heard of the Pinnacle reset system. That's a new one for
Okay.
me, so I would have to do some more work in looking into that space. Um, and I'm sorry I haven't heard about that one. There's stuff that comes up all the time, and I don't always catch it all. As for nighttime issues, yes, there's certainly so glare and light sensitivity, just like we talk about it with screens, can also be an issue with night driving, oncoming headlights. Certainly, things like that in the environment can be exaggerated in night conditions. But with some of those pupil changes as well, we can see changes in how well the visual system either adapts to dark light. So our going from a bright space to a dark space can be impacted, or going from a dark space to a light space can be impacted. And so that can also have knock-on effects and impact our night vision, as can some of those focusing issues because the pupils get bigger at night. And so in the daytime, our pupils are sometimes like pinhole cameras, and they kind of help us cheat around lots of the other uncorrected prescription and pieces like that because they work like a classic pinhole camera. But when the pupils are bigger at night, some of those uncorrected vision things can also create more issues.
Great, thank you. Robert is asking, do you have any visual therapy clinics in Toronto, or I know you're not in Toronto, or the GTA that you'd
Yeah.
recommend, or resources for patients that can't actually afford to do vision therapy, like
Uh,
self-help guides or anything like that, he's asking.
yeah. So there are some good clinics in the Toronto area and the GTA. There is a so the Canadian is there's I want to say it's COVD, the Canadian Ultimate Vision College of Vision Development, I think, is one of the groups that um, they have a practitioner, a find a practitioner link, I think, on their websites, and you can find people who do vision therapy and concussion work. I'm based in Kitchener Waterloo, so I'm not far from the GTA, but I'm certainly not within the GTA. And if you have issues driving post concussion or traveling, it can be a long journey between Kitchener and Toronto. But there are certainly some good clinics in the GTA area as well, that do vision therapy, and they're seeing, especially post concussion, and there are more and more coming up every day. So that COVD website might be a great resource. If you don't have vision therapy or coverage, or can't afford vision therapy because of its cost, there are certainly different models you can look at. So the at-home vision therapy model is one where we have less visits. So you're doing the work at home, you see a practitioner less frequently, and you have kind of a custom training program that can be effective. I've also worked sometimes with physiotherapists in a collaborative care model, because a person may have insurance coverage for physiotherapy, but not eye care. And so if I'm part of their multi-care team, we can help. I'm happy to work with their physio to try and support some of the vision stuff as best as we can through those avenues as well, because my priority is really the patient getting better, and working within their team and the models that exist. There are some programs that provide charitable care options as well. Sometimes you can explore those options. I know within our university clinics, we have some of those options available for patients. So there are sometimes foundations you can apply to for funding as well. But I think those are some of the best resources. Vision therapy is hard to do on your own. There's not a one size fits all formula. It's a
Mhm.
really tricky one to kind of just say do these exercises and they'll work, because we really need to scale them and tailor them to your ability and your level. But I think I certainly am open exploring other ways and how to do that and making it a more affordable resource for people.
Okay. And just kind of in follow-up to that, there's a question, are
Yeah,
there any websites you would
yeah.
recommend for patients doing home exercises?
It's tricky with home exercises. It's like if you think of vision therapy in some ways, if we shift our hats and think of it like um, going to a gym and working with a personal trainer, and if you're trying to do rehab after that, right? If you don't know how to use the equipment, and you don't know how to load your weights, and you don't know kind of what you're working on, it can be really tricky to build your own program without some background in that space. And it's really, nobody's gym program is going to be one size fits all either. Um, there are certainly, if you get into vision therapy and looking at some of the at home models, there are people who do vision therapy have resources to sometimes online programs, online training programs, and things like that you can do at home that might reduce your frequency of in-office visits and help reduce the cost that way. So once your whoever's doing your vision therapy can help you pick the exercises that make the most sense for you, and then you're doing some of that homework at home through a computer platform or a website, as opposed to constantly being one-on-one in the office and using the equipment in the office.
Great, thank you.
You're welcome.
Next one is this individual had a concussion August 2020, blacked out while they were running on a trail, landed on the right forehead and right eye region, glasses shattered, face cut, below eyebrow cut. Um, the local ER stated that the sinus area uh, stated there was a non-surgical fracture and hole in that sinus bone. 5 months later, vestibular therapy for 6 weeks. Past 2 years, it sounds like there's been multiple health issues. They're asking, can stress of the health issues trigger latent post-concussion issues? Is vision therapy the priority as far as post-concussion modalities?
I would say that stress and navigating stress certainly exacerbates all of those persisting post-concussion symptoms. It really is a factor that has all sorts of impacts on our health, whether you had a concussion or not. And so stress is a big piece to consider. And if adding vision therapy to your plate increases the stress of the rehab program to a point where that stress is detrimental, I don't think that vision therapy makes sense at that point. I think, it's a piece, it's a tool in your toolkit, but it's also one that should be used when it's appropriate. And it may not be that vision therapy isn't the priority for you at this point in your rehab. And then there are other things that need to be addressed first, right? It's just part of that journey, and it shouldn't make you more stressed to go through it, because it's probably going to be counterproductive that way.
Mm-hmm. Okay, great. Thank you so much. Uh, is it a common issue post-concussion to see ghost images once you close your eyes? This individual is saying, once I close my eyes, I still see what I was looking at before I closed my eyes, very clearly in black and gray for minutes
Yeah.
after their eyes are closed.
So those ghost images are called after images, and to have persistent after images can happen post-concussion. It doesn't happen to everybody, but it certainly can be another thing that lingers, and that the visual processing system just doesn't seem to clear them, or as effectively as it might have done pre-injury. We don't really understand the mechanisms of that at all, but it certainly can happen for people, and is a real experience.
Okay, great. Joseph is asking, can you comment on the use of pupillometry for diagnosing and monitoring response to care, in
Mhm.
particular pupil amplitude, average constriction speed and dilation speed, and 75% recovery time?
So I think pupillometry has a lot of great potential. It's a really, what's really fascinating about pupils from a research perspective, a neurological perspective, and a vision perspective is they are really, pupils are controlled by both our parasympathetic and our sympathetic nervous systems. So both of our sort of central regulatory nervous systems control pupil function. And so there's a lot of potential there in looking at the pupils as and their reactions and their responses to care as a biomarker of concussion and head injury and recovery. With all that being said, there's a lot of potential. The research is still, we're still learning, right? There's how that system is impacted in individuals, and the mechanisms driving the neurological changes that cause the pupil changes are still poorly understood, those underpinning mechanisms. And so it can be helpful, but I don't know that we're at a point where pupillometry gives you singular precision within a particular individual. You're going to be comparing to baselines and over time, and that larger group effect still. So lots of potential, but I don't know that we have a perfect answer there yet. Although those kind of metrics are certainly what people are looking at, and have very strong potential for being useful.
Okay, thank you.
Mm.
Adam is asking, are there simple screening tests a primary care provider can do in the office? And is asking,
Mhm.
is VOMS a good place to start?
So VOMS is a great screening test. It's certainly done early on, because VOMS is trying to figure out, if you do stuff with your vision, does it aggravate, cause symptoms? So increase your symptomatology. And that one really screens both your vision and vestibular symptoms. One of the most simple tests, really, I think that any care provider can do, and one that I often encourage people to do, is just ask people if they have trouble with their vision, right? Are they having difficulties with their vision following their head injury? Have there been changes in their vision following their head injury? And people usually can articulate that pretty well and experience that. So just even asking about some of those common vision symptoms, or if screen work or common vision tasks makes their symptoms worse, that's also probably a flag that there may be a need for vision investigation.
Great, thank you. Um, can severe, and I'm thinking this is supposed to read, this is from Barbara, can severe dry eyes um, as a result of multiple concussions be treated with optic light therapy when all other treatments have failed?
That one's tricky. So dry eye is its own standing disorder, and it's a complex disorder, complex multifactorial disorder. There are certainly some types of therapy, light therapies that sometimes can be effective. Uh, Red light therapy sometimes can be useful in dry eye, but um, certainly we see in some patients following concussion that they have an aggravation or increase in their dry eye symptoms. As we're in the dry eye research, we're starting to understand that there's certainly neurological components to the pain and the changes that we experience in the sensations in the cornea, and the contributions and symptoms of dry eye that way. Um, I am not a dry eye specialist anymore. I started my training in that world, but moved into sports and concussion spaces. So I wouldn't be able to give you the best recommendation on current care, um, other than it is very common to experience dry eye symptoms post head injury, and that dry eye is complex. And so you should be really probably working with someone who does dry eye as a specialty now to try and navigate your own journey, because it will look unique for each individual who experiences it.
Great, thank you. Paul is asking, he says, thanks for a great talk, Dr. Dalton. I'm
Oh,
wondering if
thank
you
you.
have any thoughts on adding any vision components to the next iteration of the SCAT um, for sideline concussion screening.
Uh, I certainly have thoughts. I certainly have some ideas. I think we're starting to get to a place in the vision research world where we're starting to, studies are starting to look at earlier assessments of vision and what might be predictive of prolonged recoveries, whether it be symptom questions or some, sideline assessments in the vision space. Um, I think even with it, looking at some of those, even just some possibly a convergence test on the sideline or asking about some of those symptoms potentially could be useful. But the SCAT is a very complex. It looks at a lot of different functions, and some even sometimes just asking what changes in vision might be helpful. Um, it's interesting that we're having a discussion. I was just last week at a summit meeting in Colorado, hosted by the U.S. Olympic and Paralympic Committee, looking at developing a version of a SCAT for people with vision impairment and how we might modify and change the SCAT-6 in a way to support assessment of people with vision impairment who have concussion. And I suspect as some of that work goes through validation, so content validation with athletes and people with experience, and then certainly clinical validation, we may learn stuff from that research to help inform the non-vision impairment SCAT too, and to answer some of those questions for you.
Great, thank you. Chris is asking, can eyes adjust to improper treatment and develop different problems or cement previous unresolved problems? My updated prescription post-concussion felt a bit better, but still not right. When I got a follow-up months later, the prescription was wildly different. Also, my optometrists don't seem to be aware of any special way to treat patients post-concussion. They just claim that eye lenses and prisms help.
Um, that's it. I think so. If I step back, it's like I think the visual system is very adaptable, and it has a lot of capacity to tolerate slightly imperfect visual information. Certainly, if your prescription is slightly off, especially if we're healthy, that's something a visual system is really adaptable to and can compensate for. But the visual system also has that focusing system that can engage to help us modify and compensate for, small changes in prescription or small adaptations in prescription that are perhaps less than accurate. Um, and I have certainly, we can get used to sort of a habitual visual state, and kind of that visual, those focusing muscles almost seem to charlie horse and cramp up. Um, and when that happens, it can make it really hard to assess prescription accurately, because we can't just flip a switch and get those muscles to relax. And it can certainly lead to habitual adaptations to an existing prescription over time, or changes in prescription if you've done some training or anything like that has caused those muscles to relax. So it can be tricky sometimes with the prescription piece. And that's why I like to use the cycloplegic drops and just totally relax that focusing system, get a really nice clean baseline of the prescription as best as we can, and then kind of build out from there. But certainly training can modify your tolerance for a prescription, can change your tolerance for a prescription sometimes if there are those focusing system issues and we haven't, totally gotten everything right the first time we tried, partly because of the complications that the focusing system, it impacts our ability to do that assessment accurately sometimes.
Great, thank you. There's a couple of questions that are somewhat related. Joseph is following up. He said, as you so accurately indicated, the intimate connection between the vestibular and visual system, should not vestibular therapy be delivered concurrently? And then someone was relatedly asking, how do you prioritize vestibular versus vision therapy, this, for example, for the symptoms of
Yeah.
dizziness? How do you figure out which will be more helpful?
It's we don't have a good formula. This is also Chief, by the way, so both of my cats came to visit you tonight, it seems. Um, I think it's working, it's listening to our patients, it's trying to figure out what aggravates their symptoms more. And if it seems to be driven by more vestibular stuff and motion stuff and head and neck things, and maybe vestibular therapy makes the more sense to move forward with first. If it's more engaging with concentrated visual work, concentrated visual tasks, being able to see things clearly that's driving it, maybe it's vision first. For some people, it may be working on them side by side, but that just, that'll depend on what other therapies they're also doing, right? So if it's just vision and vestibular therapy, those might work side by side well for some patients. But if there's also massage, or if there's acupuncture, or there's cranial sacral therapy, or physiotherapy on top of that, then it can be really complex, and they may not all fit on your plate at the same time. Or if they're both really sensitive issues for you, right, and they cause a flare up of symptoms, both of them, it may be too hard to work on both at the same time. And so it's really going to be listening to each patient's particular symptoms and trying to make the best choices for them. And maybe it's a stint of vestibular therapy and a stint of vision therapy and a stint of vestibular, or maybe they run in parallel, or maybe you spend time in one space and then the other. It's really going to be a little bit of listening, lots of listening on our end as care providers, but also some trial and error on your end as a patient to give us feedback on what's helpful and what's not helpful and where those limits are. Because we don't know, we can't really predict in any way what pattern's going to work best for you.
Okay, great. For someone with double vision, will it ever return to normal, and what can be done to mitigate it?
A great question. So double vision it has lots of different causes, and I think some of them can be treated and some of them are not treatable. They become persistent, and so I think figuring out the underlying cause of the double vision first is really, really important. So some causes of double vision can be trainable with vision therapy and things like that. So if your eyes naturally kind of rest, turn out from each other, we can sometimes train the muscles to compensate for that. But not always, right? It could be if there's a cranial nerve palsy or a persistent strabismus or something there, we can't retrain that nerve to function normally again if a cranial nerve is damaged in some way, in which case that double vision may be persistent or more persistent. Um, and so it may be learning to, have your head in a position that reduces it. It might be using prisms to kind of move images around to make things more single. It may mean some pieces of vision therapy to give you some control, but maybe not 100% relief from the double vision, but to reduce its impact. And sometimes with double vision, if it's really persistent, it means occluding an eye to function under binocular conditions, because that's better than working in a world that's truly two double images. But your outcome and your prognosis will depend on what's actually causing and driving that double vision in the first place.
Okay. Sheila is saying that she developed a fast-acting cataract a year and a half after concussion. Could they be related?
Maybe cataract isn't one of the ones I've heard about as commonly from concussion. Um, and it would depend a little bit on Sheila. It would depend a little bit on your age. Um, but that doesn't mean that they're not related. It may just be that it's tricky post concussion with vision stuff, because sometimes we compensate really well for small deficits in our vision before the head injury, and then small deficits become much more pronounced and irritating and aggravating post injury. And so even, cataract symptoms and that impact that has on your visual function may be less tolerable and accelerated. I really don't know. It's possible they could be related, but I don't know a distinct pathway there. We do see other aging changes accelerated. So the need for reading glasses often creeps up on people much quicker after concussion, or I often put patients in reading glasses earlier than they might have needed without that head injury, just because the impacts on the focusing system. So it's possible that some of those changes are accelerated. I just don't know the mechanisms. Unfortunately, I'm sorry.
Okay, thanks so much.
Mhm.
Okay, I think I'm going to just get in one more question. We
Sure.
are at time. Thoughts on the temporary use of pinhole glasses to reduce oversensitivity?
Um, Pinholes are tricky because they really restrict your visual field. So if it was for a specific task, possibly, but I wouldn't feel comfortable sending anyone home to walk around in pinhole glasses because you really have no peripheral visual fields and other pieces like that. If it's a short-term temporary relief in a controlled environment and that helps modulate your symptoms, I'm not going to say like if it helps turn the volume down on everything going on your symptom load, certainly if you're in a safe space, they may be helpful. But they wouldn't be something I'd want anyone driving in or walking around in because you just would lose way too much peripheral visual information. And there might be other ways to turn down the volume on your symptoms rather than the pinhole, right? So there might be other occlusion methods that we could look at, or vision training or things like that, or maybe a tint to turn down the volume that keeps both eyes open, and exploring some other options perhaps to support that as well.
Great. Okay. I think we're actually over time now, so
That's
I
okay.
definitely have to end it there. Kristine, thank you so much. That was
You're
a
welcome.
fantastic presentation, and thank you to everyone attending. There were so many questions. I'm sorry for those
Thank you.
people who I didn't get to your questions. Just as a reminder, there will be a questionnaire, very short survey coming your way. And we'd love to get your feedback, suggestions. And you can also, if you didn't get a question answered that you want answered, you can enter it in there. And you just need to provide your email address so that we actually know who's sending us the question because they are anonymous. But you can let us know and we can try and get it answered for you. Um, Also, just to let you know as well, just flagging, we've got one more session before, thank you very much, Christian, before the holidays. Now, this is going to be just flagging. This is actually taking place on a Wednesday night. We usually are always Tuesday night, but we had to tweak this for our last one in December. So it's going to run Wednesday, December the 10th, same time, and you will receive reminders for that. So thank you again, Kristine, and thanks
Thank you.
everyone. Hope you have a great evening. Take care.
Thank you. Take care, everyone.
Bye.